This 23-year-old medical student was involved in a car accident. Car collided against a tree and the vehicle turned turtle. The boy was taken to another hospital where he was evaluated and intubated. Brought to our ER on ventilator, assigned with sedation and muscle relaxant. Heart rate 95, BP 140/80, no cardiomegaly, heart sounds normal, no murmurs. There was only trauma, CT head shortness, subarachnoid hemorrhage with diffuse cerebral edema, echo study, normal heart. Over the next 2 weeks, he improved to be mobilized and to bedside chair and tracheostomy and peg feeding. This is the electrocardiogram taken at the time, which was within normal limits, with a little LV dominance. Chest X-ray on 28/9 was absolutely normal. And this was the echocardiogram. Echo on admission was also normal. On the 18th hospital day, he developed acute dyspnea and a pansystolic murmur at the left sternal border appeared to spill over the diastole. Chest X-ray showed pulmonary edema and required more oxygen for maintaining his heart rate was 96, BP low to 90/60, bilateral crepitations over lung fields. This was the electrocardiogram. My exacting minor changes. There's nothing great in the electrocardiogram. Chest X-ray was frank pulmonary edema, severe pulmonary edema, and that's why patient required more oxygen. And when you do the echocardiogram, you find that there is a rupture of the interventricular septum. There's a rupture of the interventricular septum, measuring at 2.1 centimeters. You can see the left-right shunt across the interventricular septum, both in the short axis and in the parasternal long axis. It's a very large ventricular septal defect with marked left-right shunt. But when you come to the Doppler examination, there's pansystolic shunt, but please look into it carefully. The shunt starts in late diastole, lasts throughout the systole, but it spills over to early diastole also. It's a long shunt, including late diastole as well as early diastole, indicating that. And these two phases, the LV pressure was definitely more than the RV pressure to maintain a left to right shunt. The pulmonary artery pressure was different. The pulmonary artery showed turbulence with velocity of 2.1 meters per second. And you can see the ragged edges of the ventricular septal defect. I've seen a similar ventricular septal defect a couple of years back, where also the ragged edges of the defect indicate that this is a ruptured ventricular septum and not a pre-existing ventricular septal defect. And we found that it is very close to the pulmonary valve. So it just started 3 millimeters. It's very close to the pulmonary valve and it's in the opening into the RV outflow tract. And hence, because of proximity to the pulmonary valve, we decided we are unable to do a device closure of this defect and decided to take up for surgery immediately at night itself. The LV strain was markedly reduced. You can see that the average strain was minus 7.2. LV was badly damaged and the patient was in cardiac failure, indicated by the markedly elevated RA pressure. PA pressure was 51 by calculation. And the PA diastolic was 21, mean of 35. And here you can see it. Yeah. This is the margins of the VSC. Yeah, these are margins of the VSC.
What's your levels?
It will fill with blood. Now with a subdistal. His weight. Yeah, that's fine.
Okay,
That's
stop.
the vertical just close to the back.
Yeah, okay.
And within a day, 1610, 1710, the whole pulmonary edema disappeared. The whole pulmonary edema disappeared. And post-op echocardiogram showed no VSD, intact ventricular septum, and he was very stable in the post-op room. There's no VSD at all, and he was quite stable in the post-op room. And in a month's time, 1610 pre-op, you saw that remarkable decrease of LV strain, minus 7.2. And 611 postoperatively, it is increased to minus 11.2. Remarkable recovery of the left ventricle. Recovery of the left ventricle in about 2.5 weeks' time indicated that left ventricle is far better by relieving the shunt. At the same time, look at the right ventricle. Excepting the basal segment, right ventricle was lagging behind. Right ventricular recovery took a longer time to recover. Even on 8/5/19, in a few months' time, we found 15, 19, 20. Normally, it's minus 23 or more. It should be definitely above 20. So being 15, 19, 20 or the free RV wall indicate that RV in this condition is bombarded by the volume. RV in this condition is bombarded by the pressure. So RV is damaged in two counts, one by the pressure and the volume. And not only that, RV anatomy is different. RV anatomy takes a longer time to recover, as is shown by these slides. Ventricular septal defect following blunt chest trauma is a rare but potentially life-threatening complication. Large or symptomatic lesions should be surgically repaired. In both the early and late groups, elective repair of the lesion is associated with good outcome. Mostly caused by blunt chest injuries. The mechanism of injury has been hypothesized to be related to mechanical compression of the heart between the sternum and spine, leading to a concomitant increase in intrathoracic pressure at the end of early systole. Subsequently, myocardial contusion, coronary dissection, or even adventitious hemorrhages can develop. Due to the absence of ischemic changes on electrocardiogram in our patient, the most likely primary event seems to have been myocardial contusion predisposed to rupture of the apical septum. Here it is written as apical septum, of the outlet septum. A couple of cases have been reported in the literature also. Delayed repercussions of blunt trauma. Isolated muscular ventricular septal defect. I've seen a case about 15 years back where there is a steering wheel injury to the chest. And this is a military man. And he had his ventricular septum ruptured after 3 days. He had so much of neurotrauma. Everybody thought it was neurogenic pulmonary edema. Till on the third day after the development of dyspnea, he had an echocardiogram showing a large VSD. This is the second case of delayed ventricular septal rupture I am seeing, and it is an absolutely unique scenario to deal with. Thanks, ladies and gentlemen, for kind listening, and thanks to the Bangladesh Cardiac Society for the kind invitation. Thank you. And Happy New Year to you.